Let's go over the warm-up review. First question, which elbow injury is common in tennis players and then also in golfers? So in tennis players, you're going to see lateral epicondylitis, and golfers tend to get medial epicondylitis. Next, what reactions take place in phase 1 versus phase 2 metabolism? And in general, what are the products of these reactions? So phase 1 metabolism reactions include oxidation, reduction, and hydrolysis. Phase 2 metabolism reactions include acetylation, sulfation, and glucuronidation. And then in general, phase 1 metabolism produces metabolites that are slightly more polar and slightly more water-soluble. Phase 2 produces metabolites that are very polar and therefore much more easily renally excreted. These are usually inactive metabolites. And the last question, which enzymes are required to convert phenylalanine to dopamine? So first of all, you need phenylalanine hydroxylase to convert phenylalanine to tyrosine. Then you need tyrosine hydroxylase to convert tyrosine to DOPA. Then you need DOPA decarboxylase to convert DOPA to dopamine. Now let's move on to the lecture.
Hello everyone and welcome to our Step 1 video on testicular pathology. I really like this lecture because I don't have to write an intro. From the beginning of time, the testicle has been the easiest subject matter for comedy. I think Shakespeare wrote that. Why are testicles funny? It's a mystery. All I have to say is balls, 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 and a bunch of you watching right now are smiling and some of you are even laughing out loud. It's just that easy. So sit back and enjoy my lecture on nuts and balls. See, I did it again. All right, so today we're going to cover the major pathologies of the testicles. First, we're going to talk about epididymitis. So this is inflammation of the epididymis. This is painful. Most of the time, diagnosis is just by palpation. During the testicular exam, the epididymis may be mildly swollen and it's almost always going to be tender. Now, another sign is that some of the pain may be relieved by elevation of the testicles. Although it might be a bit awkward, elevate them a little bit and then see if the pain improves. Now, the two most common organisms that cause epididymitis are Chlamydia trachomatis and Neisseria gonorrhea. Men who engage in anal intercourse are at an increased risk of E. coli. Now, the treatment is similar to urethritis, so you want to think about gonorrhea and chlamydia and that they can be treated with ceftriaxone IM doses plus doxycycline or an azithromycin one-time dose. Now, if the patient has a history of anal intercourse, you want to think about enteric bacteria. Fluoroquinolones are going to be used in this situation. Let's move on to testicular torsion. So testicular torsion is twisting of the spermatocord, which can eventually lead to ischemia. So this is a potential emergency. It is very painful. Now the diagnosis here, the classic finding is going to be that high riding testes on the affected side with the long axis of the testis oriented transversely instead of longitudinally. Now, testicular swelling may also be present. The cremasteric reflex is usually absent in testicular torsion, and ultimately, you need to get an ultrasound to look for blood flow into that testicle. Now, for treatment, rarely you can manually untwist the testes. The action is almost like opening a book. You're rotating in an outward fashion. Surgical detorsion is necessary in most cases, and then once you get a testicular torsion, you're more likely to get one again. So oftentimes they will do a bilateral orchiopexy, where they actually suture the testes to the scrotum so it doesn't happen again. Now, if you don't treat these things within about 6 hours, you can have permanent ischemia and permanent damage to the testes. Next, let's move on to cryptorchidism. So this is failure of the testes to descend into the scrotum. Now, usually it is unilateral, but it can be bilateral as well. The descent is usually complete in the first year of life. And there's an increased risk of malignant tumor in the undescended testicle, and it's usually a germ cell tumor. It's also interesting that there's an increased risk, though smaller, of testicular cancer in the contralateral, so that normal descended testicle as well. And we're not entirely sure why this occurs. Also, undescended testes may suffer from lack of spermatogenesis because of higher body temperature. One of the reasons we have testicles on the outside of our body is to provide a lower temperature for spermatogenesis. Prematurity also increases the risk of cryptorchidism. Now, early orchiopexy is the treatment. So you're going to bring the undescended testicle down into the scrotum and then suture it there to make sure that it remains in place. And this will reduce the risk of the germ cell tumors, but not completely. But just as important, if a germ cell tumor does develop in that testicle, you'll be able to detect it because it will be palpable. So early orchiopexy is usually all that's indicated in that case. Now, in the more rare scenario where there's a post-pubertal treatment of cryptorchidism, it's a more complex issue. But depending on the patient, it's going to be either orchiopexy or possibly orchiectomy, just taking out that undescended testicle. Now, what about the case of androgen insensitivity syndrome? So remember that this disorder is where the patient has male testes, but because of the androgen receptor not working, the patient develops female external genitals. Well, the testes don't have a scrotum to descend to, but they do tend to locate in the labia majora. Basically, you have two lumps in the labia majora, and again, that is an indication for orchiectomy. And in the case of bilateral non-palpable testes in a phenotypic male, it may be the case that the phenotypic male doesn't even have testes. So you need to make sure that you're ruling out congenital adrenal hyperplasia, a scenario in which the infant was exposed to excessive androgens. Here the patient has ovaries but has developed male external genitalia. Now let's move on to testicular germ cell tumors. So this can be a bit dense, but stay with me and we'll get through it. Now, 95% of all testicular tumors are going to be these germ cell tumors. They can present as a mixed germ cell tumor as well. Now, the first one is a seminoma. So it is the most common testicular tumor. About 50% of all these germ cell tumors are seminomas. It mostly affects males between the ages of 15 and 35, and it is malignant, and patients will present with a painless, homogeneous testicular enlargement. Now, on histology, you're going to see large cells and lobules with watery cytoplasm and what's called a fried egg appearance. So remember that. This is similar in appearance to the coilocytes of HPV and the oligodendrogliomas. So remember, the watery or clear cytoplasm, the fried egg appearance. Now, they are radiosensitive and have a late metastasis. So they have good prognosis because by the time you diagnose these tumors, most of the time they haven't gone through any metastasis. Now, the female equivalent of this is the ovarian dysgerminoma. So they are going to be similar cancers. Now we're going to move on to the embryonal carcinoma. So this is uncommon but malignant. So it has a worse prognosis than the seminoma. Patients will again present with a palpable mass in the scrotum, and these tumors tend to be more painful as well. Now, under the microscope, these appear more glandular with papillary morphology. This can differentiate it to other tumors. Now, the AFP alpha-fetoprotein level is usually normal, but if it is elevated, then you're probably dealing with a mixed germ cell tumor. HCG might be elevated as well. Next, we're going to move on to the yolk sac tumor, which is also called the endodermal sinus tumor. So this is the most common testicular cancer in children up to 3 years of age. Now, the appearance is yellowish and mucinous, and this is analogous to an ovarian yolk sac tumor. So yolk yellow, remember that yellowish mucinous look there. You get these Schiller-Duval bodies that resemble primitive glomeruli as well. So you see a pattern where there is a mesodermal core with a central capillary, which are lined by flattened layers of both visceral and parietal cells. Yolk sac tumors will have an elevated AFP most of the time. Choriocarcinoma. So choriocarcinoma is malignant and can cause increases in HCG, so remember that. This is a tumor with disordered syncytiotrophoblasts and cytotrophoblasts. Since you have all these syncytiotrophoblasts, that's why you see an elevation in that HCG. These tumors will metastasize hematogenously as well. And then finally, we have the teratoma. Mature teratomas in males are most often malignant. The most important thing you need to remember about teratomas is that they have multiple tissue types. So you definitely hear about hair and teeth and all sorts of nasty, gross stuff coming out of a teratoma. And these will be having elevations in HCG and alpha-fetoprotein. These will be elevated probably about 50% of cases. Next, let's move on to the testicular non-germ cell tumors. So this is only just about 5% of testicular tumors in general. Again, these are also nicer because they are mostly benign. Leydig cell tumors are the most common of the non-germ cell tumors. They contain Rinke cells. So these are lipofuscin pigment and rod-shaped kind of crystal-like structures. We're really not sure if they serve any function, but you might see that on a question. These tumors are usually androgen producing, though they can produce estrogens as well. So a patient can get both virilizing or potentially feminizing symptoms. These tumors can occur in any age but are more common in adults. Endocrine symptoms include decreased libido, erectile dysfunction, infertility. In children, we can see precocious puberty in boys, and that makes sense because you're getting too much testosterone too early. You can also see this kind of golden brown color when you look at these tumors grossly. Sertoli cell tumors, they're going to secrete excess estrogen in most cases. Patients may have a gynecomastia. 90% of these are benign. Strangely, these tumors can be associated with Peutz-Jeghers syndrome and Carney syndrome. And then testicular lymphoma. That's going to be the most common testicular cancers in older men. But this is not a primary testicular tumor. It's just a metastasis to the testes. Okay, we need to boil down the differences between all these tumors. It's time for another Lewis Notes. All right, so today we're looking at our testicular tumors, and we've got our matching game again here. We really just boiled it down to some of the biggest buzzwords for each one of these. I think if you know these, you'll be in pretty good shape. So let's get started here. We'll start out with the Schiller-Duval bodies. Where are we going to send those? Remember, our Schiller-Duval bodies are going to come over here to our yolk sac tumor. And then we have increased alpha-fetoprotein. That could go on a couple ones. Remember, in teratomas, you have about 50% elevated in alpha-fetoprotein. But for this one, I'm really going and looking at yolk sac tumors again. So yolk sac tumors are going to have an elevated LFP. What about elevated HCG? Remember, a couple of these can do it, but the big one I want you to remember is choriocarcinoma. I won't give away the answer to one of these other ones, but I'll tell you why in here in a second. Fried egg appearance. Remember, that's going to have those real watery-looking ones. That's going to be seminoma. Normal AFP, but elevated HCG. That's going to put this one over here at embryonal. Remember, that's the bad one that has poor prognosis. Most common overall is going to be our seminoma, so remember that one. Syncytiotrophoblasts. So this is the one I didn't want to spoil for you earlier, because remember, you have all these syncytiotrophoblasts and cytotrophoblasts. That's why that HCG is so high. So that's why I really want you to put in your mind choriocarcinoma and increase HCG. Very painful tumor goes along again with our poor prognosis embryonal tumors. Teeth and hair, that's the easiest one on here. You guys know that's going to be a teratoma. Most common up to age 3. So this is one that you really need to remember that maybe you don't very easily. That's going to be our yolk sac tumor again. Testosterone secreting. That one's pretty easy because remember, this is going to be our Leydig cell tumor. Remember, Leydig cells secrete testosterone. Most common in older men. Older men are going to get this lymphoma. Remember, it's not really a primary tumor, but that's going to go there. Then estrogen secreting, very easy, Sertoli cells again. And you're going to get, both with the Leydig and the Sertoli cells, you might see some gynecomastia in your men. All right, so that's going to be it for all these tumors. I hope you know this stuff, and you ought to do okay. Next, let's talk about tunica vaginalis lesions. So these are lesions in the serous covering of the testis that can present as testicular masses. Now, what's important is that they can be transilluminated in many cases. So you take a flashlight, you put it up to the scrotum, which isn't awkward. You can see something in there kind of floating around to some extent. You can see through that area right there. But it's going to be very different with a testicular tumor with something solid. You won't see anything kind of floating around when it's just a big solid mass, but you can see something when it's just fluid or blood in there. Now, the first one is a hydrocele. This has increased fluid secondary to incomplete fusion of the processus vaginalis. So this is very, very common in newborns. So when you go through your newborn rotation, you see little boys with very tight fluid-filled scrotums. So this is not a big deal. We don't get excited about this at all. These are going to resolve on their own, usually relatively quickly, but they can stick around for maybe even up to a year. We still don't do any treatment in that first year because it's benign. It doesn't cause any problems at all. Next, we have the spermatocele. This is due to a dilated epididymal duct. So there's not too many other details that you need to know about this one. Pretty low yield, but just know the name of that one. Next, we have a varicocele. Don't get a hydrocele confused with a varicocele. Varicocele is a dilated vein or veins in the pampiniform plexus that can cause infertility. And really kind of more of an association with infertility, not necessarily a cause. We're not 100% sure about that one. Now, this is a good test question that you might get. A bag of worms feeling in the area, and you can kind of feel these dilated veins. It kind of feels like a bag of worms. So varicocele, think of bag of worms in that situation. All right, guys, that brings us to the end of the lecture part. It's time for the end of session quiz. Try to answer those on your own, and then we'll go through them together. First question, a 23-year-old patient presents with one testicle. For what is this patient at risk? So we presume he has an undescended testicle, which puts him at risk for testicular cancer, specifically germ cell tumors. Next question. What testicular tumor is described by the following statement? So first we have composed of cytotrophoblasts and syncytiotrophoblasts. So this is choriocarcinoma. May present initially with gynecomastia. Think of the Leydig cell tumor and also the Sertoli cell tumors. Elevated AFP, that's going to be yolk sac tumor, and also 50% of teratomas. Next we have elevated HCG. Think of choriocarcinoma, also embryonal carcinoma and teratoma. Most common testicular tumor, that's going to be the seminoma. Most common testicular tumor in infants and children up to the age of 3 years, that's going to be the yolk sac tumor. Most common testicular tumor in men over the age of 60, think of testicular lymphoma. Histologic appearance similar to koilocytes with cytoplasmic clearing, that's the seminoma. Histologically may have an alveolar or tubular appearance, sometimes with papillary convolutions, that's going to be the embryonal carcinoma. Composed of multiple tissue types, teratoma. Histologic endodermal sinus structures, so the Schiller-Duval or Duval bodies, that's going to be the yolk sac tumor. 25% have cytoplasmic rod-shaped crystalloids of Rinke, that's going to be the Leydig cell tumors. Androgen producing and associated with precocious puberty, think of the Leydig cell tumors, maybe a Sertoli cell tumor as well. All right guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.